Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Hey, Paul, you ready to talk about heart failure with preserved ejection fraction? What's the fancy nickname for that?
I'm not sure if it's fancy. HFpEF is actually one of my more tolerable acronyms, if I'm being honest with you.
Okay, I think at first I thought you hated it. That's why okay, so you're coming around on it.
Yeah. Well, they made so many things that were much, much worse than that it looks better by comparison.
We had a great returning guest, Dr. Michelle Kittleson, absolute expert in heart failure. So, Paul, what was something she taught you about the history that you take when you're seeing someone with heart failure and how to recognize HFpEF?
And obviously, a lot of stuff that Dr. Kittleson went through. I think one of the things that I really appreciated, she talked about the tempo of exacerbations, which I maybe intuitively knew, but had never really thought critically about before. So she talks about how HFpEF, these patients can just have these sort of sporadic flares and then interval periods where they feel relatively well. So they can have an exacerbation, they need decongestion, you do that, and then they feel better after you treat them, as opposed to HFrEF, or reduced ejection fraction, where it just feels more progressive. You see sort of a shorter time in between exacerbations. It's sort of more a chronic, kind of unrelenting, inexorable kind of progression. And that's not typically what you see with HFpEF as much. I agreed with that once I heard it, but it's not something I ever sort of thought about critically. So I really appreciate that point to start.
I feel the same way, because you do have those patients you see once in a while, and you say, oh, you have heart failure listed in here. They're like, yeah, a couple of years ago, I was in the hospital for heart failure. And then, they're not even taking a diuretics in some situations.
Right. Absolutely.
Yeah. The other thing she said about the history is the company it keeps. Like if you're wondering if someone has heart failure with preserved ejection fraction, obviously older age goes along with it, but diabetes, CKD, obesity, those are pretty common things to go along with it. How about the HF2? It's the H2 HFpEF score, Paul. Oh, is that something you're using?
It's not something I'm using as such. Every so often I might do it to impress the cardiologist I'm referring a patient to, but I don't lean on it diagnostically. The way I do use it is it's a helpful reminder of the comorbidities, like you say, the company that you keep. So does the patient, are they heavy, which is maybe not the best part of the acronym, but the H part, or is their BMI elevated? Do they have hypertension? Do they have atrial fibrillation? Do they have pulmonary hypertension? Are they older than age 60, or do they have elevated filling pressures on echocardiograms? Like these are the things that typically ride along with HFpEF, or you can see with it. So I think it's just helpful to, as you're taking stock of this patient, you might be volume overloaded in front of you. Is this HFpEF or not? These can be helpful things to tip the scales.
And it's information pretty easy to get from the chart and just the general history. What you stressed to us about the history is we're internists. You have to think through the differential, because there's so many things that can cause dyspnea. There's so many things that can cause edema. So, is it coming from the heart? Is it coming from the lungs? Is it coming from somewhere else? So we talked about how to think through that as well. So don't just kind of laser in on that this has to be heart failure. It could be something else, but the HFpEF score can maybe help you a little bit be more confident in the diagnosis.
I've seen multiple patients who have nephrotic syndrome who were diagnosed with HFpEF before someone actually kind of figured out they were just pouring out protein. Yeah. So it's a great flip to remember.
I've seen that too. And we talked with her about how there's all these great drugs and a lot more evidence for HFrEF, reduced ejection fraction, but with HFpEF, Paul, there's slim pickings a little bit. But right now, there's one drug that has a class 2A, which is like, hey, it's pretty good. We have some pretty good evidence, but she thinks it's going to get upgraded to a class 1 evidence. So what classes of medications are I hinting at?
The SGLT2 inhibitors should be the mainstays of treatment. If you can at all put your patients with HFpEF on these medications, they're the ones that probably have the best evidence out of our entire armamentarium. She thinks they're probably going to be upgraded to a class 1 rating at some point in the future.
Yeah, I guess at the time they were writing the most recent guidelines, there was only one trial, but now there's been 2 trials. So empagliflozin and dapagliflozin both showed benefit. So lots of patients are getting those now, and it's easy. The dose for both of them is just 10 milligrams once a day. The other ones, I think, and this is kind of breaking news, and even after, I think it was within a couple of days of when we recorded with her and I were emailing, because the Fine Arts HF trial came out, which was finerenone for heart failure, because there was this previous trial called TopCat looking at mineralocorticoid receptor antagonists like spironolactone, did that work for HFpEF, and there was some maybe dubious stuff going on at some of the sites. Many of the sites in some countries had positive results, but other sites had no, negative results, but they also didn't have the biomarker changes that we would expect. So, what she told me is that she took this positive trial of finerenone for heart failure with preserved ejection fraction to say that most cardiologists are probably going to take this to mean that MRAs, spironolactone, and the like, that class of medications probably has a place in heart failure, and that might get an upgraded from it's a class 2B right now. Maybe it's going to go to a class 2A, maybe even a class 1 for finerenone. So that was exciting too. What about the ARNIs, Paul?
Yeah, would that they could, Matt. The ARNIs, to my knowledge so far, do not have evidence to support their use in HFpEF so much. There have not been trials that have shown any of the critical endpoints that we're kind of interested in.
Yeah.
If you have, Dr. Kittleson mentions, if you have someone whose blood pressure is challenging to control, and you wanted to try the Hail Mary pass, throwing it on there, maybe you could consider that,
right.
But it's not currently backed by the evidence that we actually have. And it's if you have access to the ARBs and the ACEs, you may as well fire all of those until the data change.
That's how I feel. That kind of drug can be pretty expensive for someone on Medicare. Maybe things are changing in 25 as we're recording this, but we'll see. And then the last class we talked about is GLP-1 agonists. There is some evidence that they can help with quality of life and symptoms. We know they help with weight loss. Some of this evidence is from the SELECT trial. And I found some pooled analysis of a bunch of different, like the STEP HF trial and the SELECT trial and some others, just kind of looking at do they actually improve cardiovascular death and hospitalization. And it does seem like in some of this pooled analysis that it does actually have some benefit on heart failure outcomes. So I think they'll get an indication in the future as well, is my guess.
Yeah, I mean, it would make zero sense if they don't.
Yeah.
Right? Obesity is a risk factor for HFpEF, and weight loss helps with OSA and atrial fibrillation, and that there is cardiovascular risk reduction shown with this class of medications.
So for you to recap, for heart failure with preserved ejection fraction, SGLT2 inhibitors, that should be your first one you go to. The MRIs, the MRAs, and the non-steroidal MRAs like finerenone have good evidence now. The ARNIs we're a bit skeptical of, but so you can use an ACE or an ARB. We favor an ARB just because we don't want angioedema for our patients. And then GLP-1 agonists, just to help with weight loss, they seem to help. And probably they're going to show benefit as we get more information in heart failure as well. If you want to hear our full discussion with Dr. Kittleson, then please click on the link in the transcript below. And with that, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
For your brain hole indeed, Matt.